Okay, let's unpack this. Imagine finding a lump on your dog or cat. It's a moment that can bring immediate concern for any pet owner.
Absolutely.
And naturally, you wonder, what exactly is this? Because, well, not all lumps are the same, are they? Sometimes they turn out to be something quite significant. Soft tissue sarcomas.
hmm
We've got a stack of detailed veterinary handbooks and guides here, really diving deep into these specific tumors in dogs and cats.
That's right. And our goal today, pulling from these sources, is to sort of cut through the complexity and give you the essential knowledge.
Yeah.
We want you to understand what these tumors are, at their core.
How they're diagnosed.
Exactly. How veterinarians approach diagnosing them, the strategies for treatment, and what the prognosis really looks like. Think of this as navigating the expert material together, really, to give you a clear, comprehensive picture.
Let's jump right in then. So, at the most fundamental level, what are we talking about when we say soft tissue sarcomas?
Fundamentally, these are malignant tumors, cancers, that originate from the body's connective tissues.
Hmm.
The technical term the sources use is mesenchymal neoplasm.
Okay.
This includes things like fibrous tissue, fat, muscle, nerve sheaths, that sort of thing.
Okay, so it's not just one single type of tumor, but a whole group.
Exactly. They are quite a varied bunch, actually,
Mm.
arising from different specific connective tissues. You'll hear names like fibrosarcoma, leiomyosarcoma,
Right.
peripheral nerve sheath tumor, mycosarcoma.
Yeah.
But the key takeaway from the sources is that they share very similar characteristics and, crucially, similar behavior when they grow.
And just to be clear, are there types of tumors that sound like they might fit, maybe because they're in similar locations, but are explicitly not part of this group?
Yes, and this is an important distinction the sources make. Tumors that arise from, say, blood-forming tissues or the lymphatic system, like hemangiosarcoma,
Oh,
are specifically not included in the soft tissue sarcoma group we're focusing on today. We're really talking about the malignant tumors of those solid structural connective tissues.
got it. So, considering they come from connective tissue, which is, well, everywhere, where do these soft tissue sarcomas most commonly show up?
Well, they can arise anywhere connective tissue is found, that's true. But the sources tell us they are most commonly seen in the skin or just beneath the skin, the subcutis.
Makes sense.
They can also originate in deeper musculoskeletal tissues like muscle or fascia, or less commonly from nervous tissue associated with blood vessels. And unfortunately, they do have the potential to spread, most often to the lungs.
Full lungs, okay.
Yeah. Metastasis to regional lymph nodes is less typical.
Okay, so we know what they are and roughly where they appear. Who is most likely to be affected? Are they common? Certain ages or breeds?
Both dogs and cats get them. The sources give us some context on frequency. They make up about 7% of skin and subcutaneous tumors in cats, and a more significant 15% in dogs.
15%? Wow.
Yeah. Looking at annual incidence, it's estimated around 17 per 100,000 cats and about 35 per 100,000 dogs are diagnosed each year.
Is it primarily an older pet issue?
Typically, yes. They are diagnosed in middle-aged to older pets. The age ranges are actually quite wide, though, 2 to 15 years for dogs and like 1.4 to almost 19 years for cats.
Wow, 1.4, that's young.
It is. And there's one specific exception mentioned, a type called bladder rhabdomyosarcoma, which can affect younger dogs.
Any strong breed or sex predispositions noted in the sources?
Not really. No strong specific breed or sex link across the board, though they do note that large breed dogs seem to be overrepresented in the statistics.
All right, let's get to the critical piece.
Yeah.
How do these tumors actually behave, and what do they look and feel like when an owner finds them? This feels really key to understanding the challenges.
Absolutely. The defining characteristic, the one that really dictates so much of the treatment approach, is their local invasiveness.
Oh,
They don't just form a neat little ball. They send out these microscopic tendrils of tumor cells into the surrounding normal tissues. And these extend far beyond what you can see or even feel during an exam.
so it's deceptive.
Very. The sources describe how they often appear to have a capsule. They call it a pseudocapsule, but this isn't a real barrier. It's just compressed normal tissue.
Right.
And the tumor cells have already breached it and are growing outwards.
So when a vet feels a lump, it might feel kind of self-contained, but invisibly, it's like an octopus with arms reaching out.
That's the analogy that really resonates from the sources, yes. Those microscopic arms or tendrils. That's why simply cutting around the visible mass isn't enough.
Right.
It's the reason wide surgical margins are so crucial, which I'm sure we'll get to.
Definitely. And beyond growing locally, do they tend to spread throughout the body? Metastasize?
Their potential to spread or metastasize, it varies significantly.
Mm.
And this is directly linked to their grade, how aggressive they look under the microscope.
Yeah.
Low-grade tumors have a low metastatic potential, but high-grade tumors have a high potential. And the most common place they spread to, the lungs.
Lungs again?
Yeah.
Yeah.
Metastasis to the regional lymph nodes, like we said, much less common.
Okay, so what would an owner typically notice that might make them suspicious? What are the signs?
Most commonly, it presents as a lump that's appeared relatively recently or maybe has been slow growing over weeks to months. It might not be painful initially unless it's pressing on nerves or something sensitive.
And what does it feel like?
On exam, the sources describe them as potentially soft, maybe fluctuant or firm.
Yeah.
And often they feel attached or adhered to the underlying tissues, not freely movable under the skin. Rapid growth isn't typical unless it's a higher grade tumor or that specific cat type, FISS.
Does the location of the tumor change the signs you might see?
Definitely. If a tumor involves a nerve, for instance, you might see signs like lameness, pain, muscle wasting, weakness, maybe even paralysis.
Makes sense.
Abdominal tumors like leiomyosarcoma in the gut can cause things like vomiting, diarrhea, weight loss, or even blockage. Tumors in the bladder, that rhabdomyosarcoma in young dogs, can lead to blood in the urine or difficulty urinating. And interestingly, the sources point out that some types, specifically leiomyoma or leiomyosarcoma, can sometimes produce substances that cause hypoglycemia, low blood sugar.
Really? Low blood sugar from a lump?
Yeah, leading to signs like weakness, collapse, or even seizures, not something you'd immediately connect to a lump, as you say.
That is unexpected. And there's a specific form in cats that's known for being particularly aggressive, correct?
FISS.
Yes, exactly. Feline injection site sarcoma, or FISS. This is a distinct, highly aggressive variant strongly associated with previous injections, most commonly vaccines, but other injections have been implicated too.
And how do those present?
They typically appear at known injection sites and are characterized by rapid growth. They feel firm and often have an irregular shape. They're nasty ones.
So why do these tumors develop? Is there a known cause or trigger? Or is it just bad luck?
For most soft tissue sarcomas, the specific cause, the etiology, is largely unknown. Just bad luck, perhaps, or combination of factors we don't understand yet.
But there are some known risk factors.
Yeah.
Yes, the sources do document several recognized risk factors or associations. In dogs, these include previous radiation therapy to an area, sometimes trauma, orthopedic implants, certain foreign bodies, and even chronic inflammation from a specific parasite, Spirocerca lupi.
Okay.
In cats, as we just touched on, there's that very strong, well-documented association between FISS and previous injections, including vaccines. The exact mechanism isn't fully understood, but the link is clear.
Okay, so if you find a suspicious lump, how does a veterinarian figure out if it is a soft tissue sarcoma and, importantly, how aggressive it might be? What's the process?
It involves a systematic diagnostic process, really.
Yeah.
It starts with a thorough initial assessment. Can you detail history from the owner? How long has the lump been there? How fast is it growing? And critically in cats, any history of injections at that site.
Right.
Then a physical exam to characterize the mass, its size, depth, mobility, if it feels attached to underlying tissues.
What other things might a vet be considering besides an STS at this point?
Oh, the differential diagnosis is broad. It could include things like an abscess, benign tumors like lipomas, other types of skin or subcutaneous cancers, or even inflammatory reactions like fungal granulomas. Lots of possibilities.
Do basic blood tests help?
Usually not much directly. Basic lab work, CBC, chemistry, urinalysis is typically normal unless there's one of those systemic effects like the hypoglycemia we mentioned with leiomyoma or leiomyosarcoma.
I know the first step with a lump is often a needle sample, a fine needle aspirate or FNA. Is that definitive for STS? Can it tell you for sure?
FNA is often the first step, yeah. And it can be helpful to rule out other common things like an abscess or maybe a lipoma, or might suggest a mesenchymal origin if spindle cells were seen. But, and this is a critical piece of information highlighted in the sources, soft tissue sarcomas often don't exfoliate well. They don't give up their cells easily on an FNA.
Ah.
So on a non-diagnostic FNA, or even one that seems to suggest something benign, absolutely does not rule out an STS. You just cannot rely on an FNA alone to exclude this diagnosis. It's a major pitfall.
That's a really important distinction for owners to understand. So if FNA isn't definitive, what's the essential next step? What do you need?
Biopsy is essential. It's the only way to get a definitive diagnosis, determine the tumor's specific type, and perhaps most importantly, its histologic grade.
The grade. That tells you how aggressive it is.
Exactly. Grade is hugely predictive of behavior and prognosis, and that drives the whole treatment plan.
How is the biopsy done? Just take the whole thing out.
Not necessarily, especially for larger or more suspicious masses. An incisional biopsy, removing just a piece of the tumor, is often preferred before planning the definitive surgery.
Why's that?
It allows you to get the diagnosis and the grade first so you can plan the main surgery properly. And the biopsy incision itself needs to be carefully planned so it can be removed completely later with the main tumor mass. Don't want to seed tumor cells.
Makes sense. What about just taking the whole lump out first go, excisional biopsy?
That might be considered for very small, freely movable masses in areas where, you can get wide margins easily. But the sources strongly emphasize that if that first surgery is for an STS, it needs to be planned aggressively for wide margins from the start. That first attempt is often the best chance for complete local control. No second chances, really.
So the biopsy gives the diagnosis and the grade. How does grading work and why is it so critical? You mentioned it drives treatment.
Right. Grading is a microscopic assessment that helps predict how aggressive the tumor is likely to be. In dogs, the modified French system is widely used. Pathologists look at 3 key criteria under the microscope.
Or
How much the tumor cells resemble normal connective tissue, there's differentiation, how quickly the cells are dividing, the mitotic count, and the amount of tumor tissue that has died off necrosis.
okay.
Points are assigned for each, and the total score determines the grade. Grade 1, low grade, grade 50, intermediate, or grade 3, high grade. And this grade directly correlates with the tumor's likelihood of recurring locally and its potential to metastasize.
Is the same grading system used effectively in cats?
For non-injection site sarcomas in cats, no single grading system is as consistently predictive as the French system in dogs. It's a bit trickier.
In FISS.
And feline injection site sarcomas, as we said, they're generally considered highly aggressive regardless of what a traditional grading system might indicate. You just assume they're bad news.
Beyond looking at the tumor itself, do vets check if it has already spread elsewhere in the body? Staging?
Yes, staging for metastasis is crucial before you embark on major treatment, since the lungs are the most common site for spread.
Chest x-rays.
Exactly. 3-view thoracic radiographs, X-rays of the chest taken from different angles are standard practice before starting treatment. If the regional lymph nodes draining the area feel enlarged, they might be sampled too, with cytology or biopsy.
And I imagine more advanced imaging is often necessary, especially for planning surgery.
Absolutely. Cross-sectional imaging like CT or MRI is invaluable. Not only can they help detect subtle metastases maybe missed on X-ray, but they are critical for surgical and radiation therapy planning.
How so?
They provide detailed 3-dimensional views, showing the precise extent of the tumor and its relationship to vital structures like bone, muscle compartments, nerves, blood vessels. This is essential for planning those wide, deep surgical margins or designing radiation fields accurately. You need to know exactly where those octopus arms are going.
All right, let's move on to treatment then. Given what we know about their invasive nature, how are these tumors typically tackled? What's the main goal?
The cornerstone of treatment, and arguably the most important factor for achieving long-term success, is aggressive local control. You have to deal with that tumor right where it is.
And that means?
And surgery is the primary treatment modality for that.
And I'm guessing, based on the octopus analogy, that surgery means cutting out a lot more than just the visible lump?
Exactly. The goal is complete excision with wide, clean margins. Because of those microscopic tendrils and the pseudocapsule we talked about, you have to remove a substantial amount of healthy-looking tissue surrounding and beneath the visible or palpable mass. That's the only way to maximize the chance of removing all the tumor cells.
And that first surgery is key.
The sources really emphasize that the first surgical attempt offers the best opportunity for achieving these clean margins and local control. It's harder to clean up a recurrence.
What are the recommended margins? How much tissue are we talking?
Historically, the gold standard was 3 centimeters of seemingly normal tissue laterally all around the tumor and at least 1 fascial plane deep.
Explain the fascial plane again.
That's that tough layer of connective tissue covering muscles or other structures. Removing it provides a critical deep barrier against those invasive tendrils.
Is it always 3 centimeters?
Some sources suggest that for certain low or intermediate grade subcutaneous tumors, maybe 2 centimeter lateral margins combined with taking the deep fascial plane might be acceptable. But 3 centimeters remains the ideal, especially for higher grade or more aggressive tumors or those fixed deeper down. And that deep margin, taking the fascia, is considered particularly vital by many surgeons.
What if the tumor is in a location where getting those wide margins is inherently difficult, like on a leg or the body wall?
Yeah, that's where it gets challenging and might require more involved, sometimes radical, surgery. For tumors involving muscles, a compartmentectomy removing the entire muscle group encased by fascia might be necessary.
And on limbs?
If a tumor is on a lower limb where achieving wide margins while preserving limb function is just impossible, amputation might actually be the most effective way to ensure complete removal and prevent recurrence.
Tough decision.
It is. Tumors on the trunk might require removing portions of the body wall, like ribs or abdominal muscle, and then reconstructing the defect.
And for those aggressive feline injection site sarcomas, even wider margins.
Yes, those are particularly challenging and demand even more aggressive surgery. Historical recommendations were 5-centimeter lateral margins and 2 fascial planes deep, or amputation for limb lesions. Their highly infiltrative nature means recurrence rates are incredibly high if excision isn't radical.
What happens if the pathologist examines the removed tissue and finds tumor cells right at the edge, what they call a dirty margin?
A dirty margin means microscopic tumor cells were definitely left behind, and local recurrence is highly likely, probably inevitable, without more treatment.
So what do you do then?
It requires further therapy. The options are typically a second, more aggressive surgery to try and get clean margins this time, or radiation therapy targeted at the surgical scar and surrounding area where the tumor was removed.
Speaking of radiation, when is radiation therapy, or RT, used more broadly for STS?
RT is a critical part of the multimodal approach, often used in conjunction with surgery. It's commonly recommended after surgery when margins are incomplete or even close, that's adjuvant RT, to kill off any remaining microscopic tumor cells.
Can it be used before surgery?
Yes, it can also be used before surgery, neoadjuvant RT, to try and shrink a large tumor and make surgical removal easier or more complete.
What about non-surgical cases?
Right. For tumors that simply cannot be surgically removed because of location or size, or if they recur after surgery, RT can be used as palliative therapy to manage the tumor, slow its growth, and control pain. Or sometimes as the primary therapy with curative intent, though that's less common than surgery.
And FISS.
And for feline injection site sarcomas, RT is often recommended even after seemingly complete surgery, just because their local recurrence potential is so incredibly high.
Are there different ways radiation is delivered? Different types?
Yes, there's definitive RT, which is aimed at a potential cure that usually involves a high total dose divided into many smaller daily treatments over several weeks.
Okay.
Then there's palliative RT, which focuses more on improving comfort or achieving temporary control. It uses a lower total dose given in fewer, larger treatments.
And stereotactics.
Right, stereotactic radiosurgery, or SRSSRT. This uses highly precise targeting, often with CT guidance, to deliver a very high dose of radiation in just 1 to 3 sessions. But this requires specialized equipment and expertise.
What about side effects from radiation? What should owners expect?
Acute side effects are common in the skin at the treatment site, things like redness, inflammation, maybe some moist peeling like a bad sunburn. But these usually resolve within a few weeks after treatment finishes.
Any long-term issues?
Potential long-term effects can include scar tissue formation or fibrosis, maybe permanent hair loss, or pigment changes in the treated area. Rarely there can be bone issues or even the development of new tumors in the radiated field many years down the line, though that's uncommon.
Is chemotherapy always part of the plan for STS?
Chemotherapy's role is primarily for high-grade tumors. Its main goal is to address the higher risk of metastasis spread to other parts of the body, or sometimes to potentially reduce local recurrence risk in really aggressive cases.
So not usually for low-grade.
Generally, it offers limited benefit for low-grade sarcomas, where the risk of spread is already low if you achieve good local control. The focus is really on those grade 3 tumors.
What drugs are typically used in conventional chemo?
A commonly used agent is doxorubicin, often given as a single agent intravenously. However, it's important to be aware of its significant potential side effects.
Such as?
Cardiotoxicity, heart problems, especially in dogs, so it's generally avoided in dogs with existing heart disease.
Yeah.
And nephrotoxicity, kidney problems, which is more of a concern in cats, so avoided if they have kidney issues.
Or anything.
It also suppresses bone marrow, which affects blood cell counts and increases infection risk. And it's a vesicant, meaning it can cause severe tissue damage if it leaks out of the vein during administration. Ifosfamide is another drug sometimes used, often in combination protocols.
I've heard about a different approach called metronomic chemotherapy. How does that work?
Yes, that's a distinct strategy. It involves giving chemotherapy drugs, typically cyclophosphamide, at a very low dose daily by mouth, often combined with an anti-inflammatory drug like piroxicam.
And the goal is different.
Right. The idea isn't necessarily to directly kill large numbers of cancer cells like high-dose chemo. It's thought to work more by targeting the tumor's blood supply, inhibiting angiogenesis, and potentially stimulating the body's own anti-tumor immune response.
When would that be used?
It's sometimes used for incompletely excised, low or intermediate grade tumors where maybe further surgery or radiation isn't an option, or perhaps as maintenance therapy after initial treatment for high-grade tumors. And it's generally much better tolerated, fewer side effects than conventional chemo.
Are there any other newer options mentioned in the sources? Targeted therapies?
The sources do mention agents like tyrosine kinase inhibitors, or TKIs, such as Palladia, tisserine phosphate. These might be used in specific protocols, particularly in dogs, depending on the tumor's characteristics, and if it expresses certain targets.
And electrochemotherapy?
Yes, electrochemotherapy is another option for local control. It involves giving a chemotherapy drug, often intravenously or directly into the tumor, and then applying brief electrical pulses to the tumor using special probes. This makes the cell membranes temporarily porous, dramatically increasing the uptake of the chemo drug right into the cancer cells. It's used for local control of masses that can't be completely removed surgically.
Okay, this sounds like a complex array of treatments, often involving multiple steps. What does the future look like for a pet diagnosed with an STS? What's the prognosis? Is it always bad news?
The prognosis is highly variable. It really depends on several factors. It's definitely not always bad news, especially for lower-grade tumors treated well. But based on the sources, the single most significant predictive factor is the histologic grade.
How does the grade influence the outcome so much?
Well, for grade first, the low-grade tumors, the prognosis is generally excellent if complete surgical margins are achieved. The risk of local recurrence is low, and the reported median survival time is typically greater than 3 years. Many are cured.
And grade 2?
For grade 2, the intermediate grade, the prognosis is generally good with complete surgery or surgery combined with radiation therapy if margins are incomplete. The recurrence risk is higher than grade the first if margins aren't clean. But with appropriate multimodal treatment, median survival is often also greater than 3 years.
What about the high-grade ones, grade 3?
Grade 3 tumors carry a more guarded prognosis. They have a high risk of both local recurrence, even with aggressive treatment, and importantly, a high risk of metastasis, usually to the lungs. These cases require aggressive multinodal therapy, typically surgery plus radiation plus chemotherapy, and even then, the median survival is typically shorter, often ranging from 1 to 2 years, according to the sources.
Are there other factors besides the grade that affect prognosis?
Yes, several other things play a role. The completeness of surgical excision is huge, as we've discussed. If margins are left dirty, the local recurrence rate is very high, often occurring within just a year.
Does size matter?
Tumor size also matters.
Yeah.
Larger tumors, generally those over 5 centimeters, tend to behave more aggressively and might have a poorer prognosis.
Location?
The tumor's location can impact the local prognosis, mainly because it dictates how easy or difficult it is to achieve those adequate wide surgical margins. A tumor wrapped around the spine is harder to deal with than one on the flank, for example.
And you mentioned species before.
Right, species is relevant. As we noted, feline injection site sarcomas are typically more aggressive and have a higher recurrence rate than most canine STSs, even comparing them to higher-grade canine tumors.
Does the treatment plan itself impact prognosis? How aggressively it's treated?
Absolutely. Aggressive multimodal therapy combining surgery, radiation, and potentially chemotherapy as indicated by grade and staging generally leads to better outcomes, especially for those higher-grade tumors or ones that weren't completely removed initially. The sources indicate that cure is possible, particularly for low and intermediate grade tumors, when they are treated definitively early on with wide surgery or surgery combined with radiation therapy.
After treatment, assuming it goes well initially, what kind of follow-up is needed? How do you monitor?
Monitoring is essential to detect any local recurrence or distant spread early when it might still be treatable. The recommended protocol generally involves regular physical exams with careful palpation of the surgical site or radiation field.
Feeling for new lumps?
Exactly. And repeat thoracic radiographs to check the lungs for metastasis, since that's the most common site of spread.
How often?
The typical frequency recommended in the sources is every 3 months for the first year after treatment. That's when most recurrences or metastases tend to show up if they're going to. And then, if all clear, maybe stretching out to every 6 months thereafter.
Can these tumors be prevented? Is there anything owners can do?
For most soft tissue sarcomas, Since the cause is largely unknown, general prevention isn't really possible. However, there are important proactive steps cat owners can take, specifically regarding feline injection site sarcomas, given the known link to injections.
What are those crucial steps for cat owners? What should they know?
Because of that link, the strong recommendation from the sources is to administer vaccines and other injections in locations where, if a sarcoma were to develop, definitive surgery like amputation would be feasible.
Where exactly?
Places like a distal part of a limb low on the leg, or perhaps in easily resectable sites like the tail or the distal lateral thigh away from the main body trunk. This allows for curative intent surgery if, unfortunately, AFIS does develop.
Any other considerations for cats?
The sources also mentioned discussing the use of non-adjuvanted vaccines where appropriate with your veterinarian, as adjuvants, substances added to vaccines to boost immune response, have been implicated, though the link isn't perfectly straightforward.
And there's a really specific rule for cat owners to help identify potential FIS early, isn't there? The 3-2-1 rule.
Yes, this is a key takeaway from the sources for every cat owner, the 3-2-1 rule. For any lump that appears at an injection site, you should pursue a biopsy, get it checked properly for any mass in an injection site in your cat, persists for 3 months after the injection.
3 months, okay.
Is greater than 2 centimeters in diameter at any point.
2 centimeters.
Or increases in size 1 month after the injection was given.
3-2-1.
Got it. Following this rule is vital for early detection, which significantly improves the chances of successful treatment for FISS. Don't wait and watch these lumps in cats.
This has been incredibly informative, really covering a complex topic in such detail. To kind of wrap it up, if you're a pet owner facing this or is wanting to be informed, what are the absolute key messages the sources emphasize that you should understand and discuss with your vet?
Okay, I think, first, understand the fundamental nature of these tumors. They are malignant connective tissue cancers, and their defining characteristic is that aggressive local invasiveness. Remember those microscopic tendrils reaching out?
The octopus.
The octopus, exactly.
Sure.
Second, recognize the absolute necessity of a definitive diagnosis, including that histologic grading via biopsy, because grade dictates so much of the prognosis and the treatment plan. Don't rely on just an FNA. Third, grasp that aggressive local control through surgery with wide margins is the primary treatment and the most critical factor for success, even if it means removing more tissue than initially expected, or a more involved surgery like amputation.
And it's not just surgery alone often.
Fourth, be aware that multimodal therapy, combining surgery with radiation and sometimes chemotherapy based on the tumor's grade and stage, is often necessary for the best outcome, particularly for higher grade or incompletely removed tumors.
And managing expectations throughout the process seems crucial too.
Yes, absolutely. Understanding the potential for local recurrence and the risk of metastasis, particularly with higher grade tumors, is part of setting realistic expectations. Also, being prepared for the potential costs associated with advanced diagnostics and comprehensive treatment. But remember, the ultimate goal is always to achieve the best possible outcome while maintaining a good quality of life for your pet.
And acting early.
Yes. Early and aggressive initial management, starting with that first surgery being planned correctly, is consistently recommended in the sources for optimal results in both dogs and cats.
It sounds like getting specialized expertise involved, like an oncologist or surgeon, is often highly recommended for these.
For these complex and potentially challenging cases, yes, the sources often suggest considering referral to a board-certified veterinary surgeon or oncologist. Their specific expertise in diagnosing, staging, planning complex surgeries or radiation, and managing chemotherapy can make a significant difference in outcomes.
This has been a truly deep dive into soft tissue sarcomas. We've gone from understanding what they are and how they behave, through the crucial steps of diagnosis and staging, the comprehensive treatment approaches involving surgery, radiation, and chemotherapy, and what factors really determine the prognosis. Knowing all this really equips you as a pet owner to have a much more informed conversation with your veterinarian about any lump you might find on your pet. You can better understand the why behind the recommendations for diagnostics and treatment.
It really shifts the conversation, doesn't it? From simply removing a lump to developing a strategic plan tailored to the specific nature of that tumor, maximizing the chance for a successful outcome.
Definitely. So here's a final thought. Given how critical that very first surgery is, and how the microscopic invasive nature of these tumors requires removing significant amounts of what looks like healthy tissue around a lump that might otherwise feel quite distinct, does understanding that unseen biological behavior, those octopus arms, fundamentally change how you think about the simple act of identifying and removing a lump? It certainly adds a layer of complexity and maybe urgency to that initial finding, doesn't it?